2 in the morning, in StAMPSville. A 34-year-old First Nations woman is brought in by her cousin. Severe asthma since childhood. She cannot finish a sentence.
D-85. Foundation phase, 85 days out from the exam. This is the scenario that separates a pass from a fail. What do your first 60 seconds look like?
Call for help while you walk to the bed. Senior nurse, second nurse, the Aboriginal health worker on nights. Sit her upright. Oxygen on, nebs running, monitoring on, everything in parallel.
Name the drugs. Exact drug, dose, route.
Salbutamol 5 mg plus ipratropium, 500 micrograms, nebulized, oxygen-driven. Repeat every 20 minutes, 3 cycles, then continuous if she is not improving. Oxygen titrated to keep SATs above 94% for asthma.
And the steroid?
Prednisolone, 37.5 to 50 mg orally, or hydrocortisone, 100 mg intravenously if she cannot tolerate oral. The Australian Asthma Handbook says within 1 hour of presentation, in practice, in the first 10 minutes.
Why the obsession with early steroids?
They take hours to work. The earlier they are in, the earlier the airway inflammation starts settling, and they reduce admission when given in that first hour. Late steroids are rescue theatre.
She has used 2 reliever canisters this month. What does that tell you before you even examine her?
Red flag. Ambulance Victoria lists frequent reliever use, more than 12 canisters a year, as a risk factor for life-threatening asthma. 2 in a month means her underlying control is chaotic and her preventer has failed, or she never had one.
Which is the real diagnosis hiding under this presentation?
Exactly. The exacerbation is the visible event. Uncontrolled asthma with no inhaled corticosteroid coverage is the disease. The fellowship answer treats both.
So while the nebs run, what 4 history questions actually change your management tonight?
1. Is she taking a preventer at all? And if so, how often in the real world, not the script? 2. Has she ever needed intensive care or intubation before? 3. What triggered this? Virus, dust, smoking in the house. 4. Does a written action plan exist and did she use it? Each answer moves a decision tonight and everyone moves the plan next week.
Previous intensive care. Why does that single word matter so much?
It is one of the strongest markers we have for a future fatal attack. Alongside a recent emergency visit inside 4 weeks or more than 3 in a year, that history pushes me to retrieve earlier and observe longer, whatever tonight's numbers do.
Triggers in her world specifically. She is First Nations, Regional Victoria, works the pits.
Viral infections top the list, then mine dust and diesel, smoke in the house, mold in housing, and in this state one thing every Victorian candidate must own: epidemic thunderstorm asthma, grass pollen season, October to December, ryegrass belt, storm fronts shattering pollen into the airway. The Victorian Health Department runs a forecasting and warning system for exactly this. Severe asthma plus reliever overuse is the high-risk profile and her action plan names those days.
November in Victoria. Why does that month matter in an exam answer?
Because the world's largest epidemic thunderstorm asthma event hit Melbourne in November 2016. Thousands presented in hours, intensive care filled, and people died. The system's answer since then is forecasting, warnings, preventer adherence, and action plans that tell high-risk people to stay inside. Windows shut, reliever accessible on high-risk days.
Walk me up the severity ladder. Where is she now?
Cannot complete a sentence. Respiratory rate 32. SATs 91 on air, using accessory muscles. Tracheal tug. Pulse 118. That is severe asthma by the handbook definitions, not yet life-threatening.
And peak flow. The number every medical student reaches for.
In severe distress, it is often unusable, and I would never delay treatment to chase it. If she can blow, I compare against her personal best, not predicted. Under a third of best is life-threatening. But the bedside signs, speech length, accessory muscle use, respiratory rate and behavior carry more weight than a number she cannot generate.
1 hour in, what does a good response actually look like, and what does a bad one trigger?
Good means speaking in sentences, respiratory rate falling into the 20s, SATs holding on less oxygen, and if she can blow, peak flow climbing past half her best, then I space the nebs out and watch. Bad means still single words, still accessory muscle use or any deterioration. The nebs go continuous, the magnesium goes in, and the retrieval call moves from standby to confirmed.
What tips are into life-threatening?
Any one of a silent chest, exhausted or drowsy or confused, SATs below 90, poor respiratory effort, cyanosis, bradycardia, arrhythmia, hypotension, or peak flow under a third of her best. And one trap, a rising carbon dioxide in a patient who looks calmer is not improvement, it is pre-arrest.
Say that again slowly, because that trap fails candidates.
As she tires, the chest gets quieter and the patient looks less distressed. The blood gas shows the carbon dioxide climbing. That quietness is respiratory muscle failure, not bronchodilation. You escalate on the gas, not on the vibe.
What point of care tests are you actually running at 2 in the morning? 300 kilometers from a formal lab.
Bedside venous or arterial gas, electrolytes including potassium, lactate, hemoglobin, ECG, plain chest film once she is stable enough to sit for it. That is the toolkit.
Interpret 2 numbers you expect to confuse people.
Potassium falls because beta agonists drive it into cells after repeated nebs. Lactate rises from the beta agonist itself. Neither means sepsis. Know the physiology and you will not chase ghosts.
ECG and troponin in a 34-year-old. Defensible or reflex?
Defensible. Tachycardia to 130 plus raises the question of a primary arrhythmia driving the wheeze, and a right heart strain pattern nudges the embolism question. Troponin and glucose on the point of care machine cost minutes in close loops, and the chest film, once she can sit, is for the pneumonia, the pneumothorax and the wet lung, not for tension. Tension never waits for film.
One more oxygen decision at the door. She arrives, SATs 84 on air, gasping. 8 liters mask or controlled flow.
For asthma, oxygen is not the enemy. High flow mask now. Titrate down as the SATs recover. Target above 94. The caution about over-oxygenation belongs to to the COPD patient, not the young asthmatic who is hypoxic. Treat the patient in front of you, then recheck the story.
She is your only doctor for 295 kilometers. Before you lock in asthma, what else kills this presentation?
4 things I actively clear: anaphylaxis, tension pneumothorax, pulmonary embolism, and seated pneumonia with sepsis physiology. Then the common ones: infective bronchitis, wet lungs from failure, vocal cord dysfunction.
Anaphylaxis first. How do you clear it in 30 seconds?
Sudden onset after a food, sting or drug, skin or gut involvement, circulatory collapse, asthma plus any of those is anaphylaxis until proven otherwise. And the treatment is adrenaline intramuscular, half a milligram of 1 in 1,000 for an adult, outer mid-thigh, repeated every 5 minutes if needed.
Adrenaline first, nebs second. Yes?
Yes. Bronchodilators alone do not fix anaphylaxis. Adrenaline is the first-line drug under the ASIA guidelines, and undertreating is more dangerous than overtreating.
And if it does turn out to be anaphylaxis and she responds, what is the observation rule and the discharge pack?
Observe at least 4 hours from the last adrenaline dose, because biphasic reactions are real. Overnight, if the reaction was severe or needed more than 2 doses, the trigger is unclear, or they live remotely. Discharge with 2 injector devices, a written action plan, training in the actual device, and an allergy referral pathway.
Tension pneumothorax. Your X-ray machine exists. Do you use it?
No. Tension pneumothorax is a clinical diagnosis, and decompression comes before imaging. Hypotension, hypoxia, unilateral silent lung, maybe tracheal shift late, 14 or 16 gauge cannula, 5th intercostal space, anterior axillary line.
Why the 5th space, anterior axillary line, and not the traditional 2nd space midclavicular?
Chest wall thickness. The Victorian State Trauma System guidance and the pooled data show the 2nd space fails because the chest wall is thicker there. The anterior axillary site has the lowest failure rates. Then a formal intercostal catheter once she is decompressed.
Pulmonary embolism in a town with no CT. What is your move?
Pretest probability from history and examination. D-dimer is not available at 2 in the morning, so it is a gestalt plus ECG plus gas, and if the suspicion is real, the retrieval conversation happens with that on the table. Sometimes the answer is treating and transferring with the question open.
Give the examiners the common ones too. The things this will be 90% of the time.
Infective bronchitis on top of asthma, a community-acquired pneumonia with wheeze heard through it, acute heart failure with wet lungs and maybe atrial fibrillation, and in the younger patient, vocal cord dysfunction, which is dyspnoea, and noisy breathing that barely responds to salbutamol, and has a flattening inspiratory limb. None of those excuse undertreating an asthma attack tonight.
Back to your patient. 2 cycles of nebs in, steroids in, SATs 93, still speaking single words. What is the next drug on the list?
Intravenous magnesium sulfate, 0.2 millimoles per kilo, maximum 10 millimoles, diluted, infused over 20 minutes. Second line when severe asthma is not responding to maximal inhaled therapy.
Victoria pre-hospital would do the same thing?
Ambulance Victoria runs 10 millimoles, 2.5 grams, diluted to 25 mils, over 20 minutes for critical asthma. Same drug, same discipline. It never replaces inhaled therapy, and nebulized magnesium is not recommended in Australia.
Monitoring while the magnesium runs?
Blood pressure every few minutes, it can drop, and the response of the workup breathing over the following 30 minutes. And 2 things I am deliberately not giving: aminophylline, weak evidence in a narrow therapeutic window, only with senior guidance, and routine antibiotics, because asthma is not a bacterial disease unless the chest film and the fever say otherwise.
What if she were 34 weeks pregnant with the same attack?
The plan barely moves. Steroids, nebs, magnesium all stand, and magnesium has a long obstetric track record. Adrenaline still goes in if it is anaphylaxis. She is retrieved with the pregnancy tagged in the conversation, because she needs a center that can look after 2 patients if she delivers. Never withhold acute asthma treatment for pregnancy.
Give me the 2-line summary a rural generalist can hold under pressure.
Oxygen, continuous salbutamol with ipratropium, early steroids, magnesium if severe and not responding, adrenaline only if anaphylaxis is on the table, and prepare for the airway while the plane is mobilizing.
There it is. The plane. Say the retrieval arithmetic out loud.
The aeromedical service is 900 kilometers away, roughly 90 minutes flying once airborne, plus mobilization and refueling stops, so the realistic window between my call and their boots on the floor is 2 to 3 hours.
So when do you call them?
At the point of suspicion. The moment I label this severe asthma, I am on the phone while the nebs are running. Calling early costs a stand-down message. Calling late costs a roadside intubation.
Meanwhile, in your own department, name 2 things that make her worse while everyone waits.
Lying her flat, and sedating her because someone mistakes exhaustion for anxiety. Keep her sitting up, keep the room calm and quiet, and treat agitation as a hypoxia signal until proven otherwise. The patient who suddenly stops fighting may be the one about to arrest.
Hold that thought, because the question that decides the station is not the drug list. The aircraft is 90 minutes out at best. What exactly happens in this department over the next 90 minutes, and who does every single job?
Sign it out loud. 1 nurse on continuous nebs and monitoring, 1 on observations and documentation every 15 minutes, the Aboriginal health worker with the family and watching her between nebs. I hold the drugs, the airway plan and the retrieval line.
Escalation is a written thing here, or a feeling?
Written. SATs below 90, carbon dioxide climbing, drowsiness, heart rate falling, silent chest, anyone. The airway trolley comes to the bedside. Everyone in the room knows the triggers before I say them.
The Aboriginal health worker watching her between nebs. Why is that a clinical role, not a comfort role?
Because deterioration in the quiet phase is behavioral before it is numerical. She stops answering, she gets agitated, she lies down. The health worker knows her normal and her family. That is early warning data no monitor gives you.
Intubation. You are the anesthetist tonight. Drug dose and the ventilator mistake that kills asthmatics.
Ketamine, 1 to 2 milligrams per kilo. It preserves respiratory drive and bronchodilates. Succinylmethonium or rocuronium per anesthetic judgment. The killing mistake is breath stacking. You set a slow rate, 6 to 8, long expiration, 1 to 4 ratio, small tidal volumes, 6 to 8 mils per kilo of ideal body weight, and you tolerate a high carbon dioxide.
She drops her pressure the second the ventilator starts. What do you do with the circuit?
Disconnect and squeeze the chest manually to let the trapped air out. That hypotension is auto-PEEP, intrathoracic pressure strangling venous return, not volume depletion. Flush fluids, reconnect slower and longer expiration, and escalate.
Capnography in the ventilated asthmatic. What does the waveform tell you?
A sloping upslope means obstruction still loaded, and a rising carbon dioxide with a falling level of consciousness means the ventilation is failing. And if she arrests on you, the airway differential is brief. Bilateral decompression, then bilateral finger thoracostomies if the pressure is not released, because tension and breath stacking in a young asthmatic can be indistinguishable at the bedside.
Consent. She is still with it enough to talk in words. What happens before you ever push ketamine?
The conversation happens now, with the Aboriginal health worker present, in plain language, family in the room if she wants, what intubation means, why the transfer, what the risks are, and who is making decisions if she cannot. Documented before sedation, always.
And if the weather grounds the aircraft?
Plan B is on the table at the 60-minute mark, not when the phone rings. Road transfer 295 kilometers with a road ambulance and escort if she is stable enough, or stay, treat and run hourly reassessment with video intensive care support. The decision, the reasoning and the timing go in the notes.
Let me age her 34 years, 68-year-old smoker, the same wheeze, the same 2 in the morning. What changes in the first 5 minutes?
Almost everything. This is likely a COPD exacerbation with a risk of type 2 respiratory failure. First change, the oxygen. Target 88 to 92%. Controlled. 1/2 to 2 liters via nasal prongs. Over-oxygenation in COPD kills.
The nebs too?
Driven by air with titrated oxygen. Not 8 liters of oxygen through the nebulizer. Bronchodilators the same. Salbutamol and ipratropium. Steroids. 30 to 50 milligrams of prednisolone daily for 5 days. Antibiotics only if the sputum has increased in volume and turned purulent or she is febrile. Doxycycline or amoxicillin. 5 days.
The number that decides whether this becomes a ventilator conversation.
A blood gas, pH below 7.35 with carbon dioxide above 45. Non-invasive ventilation is the answer, and it is a mortality benefit, not a comfort measure. It cuts deaths, intubations, and length of stay.
Venous or arterial?
Venous gas screens. A venous pH of 7.34 or less sends me to arterial. The arterial gas confirms, stages, and then titrates the ventilation.
You start non-invasive ventilation at 2 in the morning in a hospital with no resident medical officers. What must be written at the moment it goes on?
The escalation plan and goals of care. COPDX is explicit. Who monitors, what the 1-hour reassessment is, what happens if the pH is not moving, and whether this patient would want intubation if it fails. That conversation happens at initiation, not at 4 in the morning in a crisis.
Practical non-invasive ventilation in a hospital with no resident doctors overnight. Mask, machine, monitoring.
A well-fitted mask beats high pressures. Start around 10 to 15 inspiratory, 4 to 5 expiratory, and titrate to the rate and the gas, not to comfort alone. Arterial gas at 1 hour, then regular reassessment. A trained nurse sits with the patient, skin checks, breaks, reassurance because tolerance is the therapy. If the pH is flat after an hour or 2 despite escalation, that is the intubation conversation, and it is had early.
When does the COPD patient get the retrieval call rather than the ward bed?
When the pH is flat or falling after an honest hour or 2 of escalation, when exhaustion or confusion grows, when the mask cannot be tolerated, or when the comorbidities, the failure, the kidney function, mean this chest will not recover on a general bed alone. Same principle as the asthma. The call is a clinical judgment made early, with a plan B written down.
She survives the night on the ward. Discharge plan, before the teaching moment evaporates?
Pulmonary rehabilitation referral before she leaves. It is one of the few interventions that keeps COPD patients out of hospital. Vaccination status updated. Influenza, pneumococcal, COVID, inhaler technique by teachback. Because a device used wrongly is a device not prescribed. A smoking cessation offer, brief intervention plus pharmacotherapy, made every admission, review inside a week, and an exacerbation action plan so the next one starts steroids early instead of ending in an ambulance.
Back to our 34-year-old. 90 minutes later, magnesium in, 3rd neb cycle running, she is speaking short phrases. SATS 95, rate 20. The plane is on the ground. Who goes?
She does. Life-threatening or refractory severe asthma belongs in an intensive care unit, and a retrieved transfer with an intubation-capable team is the safe corridor. I have stabilized her. I have not cured her. She can retention in the aircraft.
And what the retrieval consultant wants from your first phone call, 60 seconds, structured.
Age, the diagnosis and severity right now. The gas is what I have given and when. The trend since arrival. Comorbidities and the pregnancy question. My concern in one line. What I am asking for, and my callback number. Situation, background, assessment, recommendation. The same discipline as the handover at the aircraft door.
And while the team packages her, what is happening to the record?
Time-stamped entries as we go. Not reconstructed at dawn. Drugs with dose, route and clock time. Gas results with the time drawn. Who was informed and when. The consent conversation, and the pre-alert to the receiving unit. In a small hospital, the notes are the spine of the handover, and if this ends in a review, they are my defense and the family's answers.
The team itself. 2 nurses and a health worker just ran a 2 in the morning resus. What do you owe them before the shift ends?
5 minutes of hot debrief at the bedside trolley. What went well? What was hard? One thing to change. Name the stress. Check everyone is safe to drive home, and flag anyone who needs follow-up. Rural teams see each other at the shops tomorrow. Looking after the team is clinical governance, not a luxury.
Could you make the case to keep her?
If she were moderate, fully responding, normal gas, I would admit her overnight locally, observe at least 4 hours after resolution, and discharge on a proper regimen. But this presentation, with the reliever history and a near silent chest at peak, gets transferred. The examiner wants the retrieval logic, not the hero logic. logic.
Say the discharge plan as if she stayed, because the follow-up is where rural marks live.
Complete the prednisolone course, 5 to 10 days total. Ensure she is on an inhaled corticosteroid containing preventer at medium dose, because this attack tells you her airway needs it. Spacer and technique checked by teachback before she leaves the building.
And the appointments?
Booked before she walks out, not left to her to arrange. Review with her own clinician within 3 days. Comprehensive asthma review in 2 to 4 weeks. If she has had more than one emergency visit in 12 months, specialist respiratory review. And in StAMPSville, the discharge summary goes to the Aboriginal Community Controlled Health Service with her consent, and the health worker owns the recall.
What goes in the written action plan itself?
Her usual medicines, how she recognizes worsening, reliever needing repeating inside 3 hours, night waking, symptoms dragging over 2 or 3 days, when to start the prednisolone course, and she leaves with the tablets, and the escalation line in plain words, when to ring the clinic, when to come in, when to call the ambulance. A plan she can rehearse at the kitchen table beats a pamphlet in a drawer.
If she does not show up on day 3?
A did not attend note is a system failure, not a patient failure. Phone. Then the health worker makes a home visit. The recall pathway is part of the treatment plan, and I say that in the station out loud.
Zoom out. What is actually killing people in this scenario across Australia?
Preventer underuse. Most fatal or near-fatal asthma in this country happens in people who are not on inhaled corticosteroids, or who stop them, often with an overused reliever sitting in their bag. The reliever masks the decline, while the inflammation marches on.
So the system's answer sits upstream of the 2 in the morning.
Preventer access and adherence, written action plans, spacer technique, trigger control, and follow-up that survives distance. That is the population health layer of the same disease.
Give the layer its numbers.
Australia still records hundreds of asthma deaths a year, and they cluster in exactly this profile. People who drifted off preventers with a reliever in every bag. For First Nations communities, the burden runs heavier, tied to housing, smoke exposure and access. The annual review with a refreshed action plan, influenza, COVID and pneumococcal vaccination, smoke-free housing and smoke-free fires. That is chronic disease control doing emergency medicine in slow motion.
Her triggers include mine dust. She works the pits.
Then the occupational threat is real. Respirator fit, exposure logs, a letter to the employer with her consent, and consideration of a work-related assessment. For a First Nations worker on mine income, protecting the lungs and the job are the same task.
Examiner lens time. Walk into the station. What does the assessor hear in your first 30 seconds?
Signposted skeleton, initial assessment and immediate priorities, focused history and examination, differential diagnoses with the killers cleared, investigations available here, treatment with exact drugs and doses, then disposition, retrieval, and follow-up. I say the skeleton, then I walk it.
And the candidate who forgets the family and the health worker in the station, what do they lose?
More than style marks. In a First Nations community, the health worker is a clinical asset in the assessment, the consent and the recall, and the family is part of the safety net. Naming them, with jobs and times, shows the assessor you can run a small rural team, which is the entire point of this exam.
Where do most candidates leak marks in this exact station?
Vague drug language, nebulized bronchodilators, some steroids, consider magnesium. The assessor wants salbutamol 5 mg, prednisolone 50, magnesium 0.2 millimoles per kilo max 10, exact drug, dose, route, and the retrieval call placed in parallel, not in sequence.
And the style side of the 60-40 split?
Structured, honest about uncertainty. If I do not know the local retrieval number, I say who does. Signposting before each move, summarizing after each block, and closing every loop, results, follow-up, safety netting, and the review that owns them.
One more layer. Yesterday we sat at a kitchen table with an elder on 9 medicines. Connect today to that visit.
Same skill, different lungs. That kitchen table reconciliation is where I would have found this woman's 2 empty reliever canisters and the uncollected preventer script. The triple whammy, an ACE inhibitor, a diuretic and an anti-inflammatory together, is the pharmacological cousin of reliever overuse. Both are prescribing system failures you can see coming.
Name the triple whammy properly, for anyone who missed yesterday.
An angiotensin-converting enzyme inhibitor, a diuretic and a non-steroidal anti-inflammatory together. The diuretic dries the kidney, the inhibitor drops its perfusion pressure, the anti-inflammatory closes the afferent arteriole. 3 tolerable drugs, 1 acute kidney injury. The fix is deprescribing at the kitchen table with the actual bags in front of you.
Give me the sick day rule that links them.
SADMANS, the medicines you suspend during dehydrating illness, sulfonylureas, ACE inhibitors, diuretics, metformin, angiotensin receptor blockers, non-steroidal anti-inflammatories, and SGLT2 inhibitors. Same discipline as an asthma action plan. Written, on the fridge, rehearsed before the crisis.
A blood test trap from that visit.
An HbA1c of 53 millimoles per mole can hide valleys and peaks. The pattern matters as much as the average, and for First Nations patients with kidney disease, you refer on the trajectory of the eGFR curve, not on a single number crossing a threshold. Every result has a named donor who checks it.
Rapid recall. 5 questions, short answers. First, oxygen target in COPD exacerbation.
88 to 92%. Controlled flow.
Second, magnesium dose in severe asthma.
0.2 millimoles per kilo. Maximum 10 millimoles, over 20 minutes.
Third, adrenaline and anaphylaxis. Adult dose and site.
0.5 milligram intramuscular, outer mid-thigh. Repeat every 5 minutes.
Fourth, the gas threshold for non-invasive ventilation in COPD.
pH below 7.35 with carbon dioxide above 45 millimeters of mercury.
Fifth, the observation window after an anaphylaxis reaction settles.
At least 4 hours from the last adrenaline dose, because of biphasic reactions. Longer if risk factors.
Last word. 3 things you must say in this station.
1. Exact drugs, doses and routes, with steroids in the first hour, and magnesium for refractory severe disease. 2. Retrieval called at the point of suspicion, in parallel with treatment, with a written 90-minute interim plan and delegated jobs. 3. A discharge architecture that survives distance. preventer insured, spacer taught back, written action plan, review booked before departure, and a recall, with a name donor.
Tomorrow D-84, an older woman, breathless and confused, on 10 medicines and a 7-day review all at once. Bring the kitchen table.
Until then, this is independent exam preparation, not official college material, and nothing here replaces clinical judgment or local protocols. See you at D-84.